Welcome to Live from One Cancer Place. I'm Sarah Kelly. Today on Live, our own Dr. Chris Heery, Chief Medical Officer at Arcellx, is joined by Dr. Mark Lewis and one of OCP's favorite patients, Shauna Gruwell. Dr. Lewis is the Director of Gastrointestinal Oncology at Intermountain Health. He serves on the Board of Directors of Neuroendocrine Tumor Research Foundation, as Vice President of American Multiple Endocrine Neoplasia Support, and as Chair of Digital Engagement for the SWOG Cancer Research Network. Dr. Lewis received his medical degree, completed his internal medicine residency, and served as Chief Resident at Baylor College of Medicine in Houston. After completing a hematology oncology fellowship at the Mayo Clinic in Rochester, Minnesota, where he served as chief fellow, he returned to Houston, where he worked at the University of Texas MD Anderson Cancer Center with a dual appointment in general and gastrointestinal medical oncology from 2012 to 2016. We are so glad to have you here today to join us. And I would like to thank our founding partner, Seagen, and our supporting partners, Colorectal Cancer Alliance, Natera, Colon Cancer Coalition, and Mirati Therapeutics. Dr. Chris, go ahead.
Thanks, Sarah. It's a great introduction. So, Mark, we heard your backstory a little bit, or at least your sort of professional version of yourself from Sarah. But I think it'd be, if you don't mind, maybe giving us a little bit more of your backstory and how you became focused on cancer as the target of your life's work.
Absolutely. No, thank you so much, Chris. And before we go on, just a real brief, almost housekeeping. Thank you so much to Sarah for the lovely introduction, to Erica for the invitation, to One Cancer Place for this forum, and then to Shauna, who we'll get to, I think is probably the most important person on the call from my perspective. So yes, I think the reason I'm here is I am a physician, but I'm also a patient, and I always live on the front part of that patient-physician hyphenate. And Chris, you're so kind to ask. It's interesting, I suspect this audience may be somewhat kind towards oncologists. I think our public image is probably not as fair. I think we are sometimes portrayed as, chemo dispensing mad scientists. Sometimes people say that we poison our patients. But actually, if you dig just a little bit below the surface of almost every oncologist I know, you find this mixture. I call it the head and the heart. Our brains, our intellects are in love with the science, and then our hearts, we have some sort of humane reason for entering the field. And in mine, it was the fact that cancer runs in my family. So I know this is an international audience. When I was 8 years old, my family actually moved from the UK to America. And part of that process as a public health measure that long precedes COVID is, as an immigrant, you have to get a chest x-ray. And what they're looking for is tuberculosis. So we got this call from the embassy to my father saying, well, good news and bad news. Good news is you don't have TB, but the bad news is something is occupying almost the entirety of your right lung. And when you get to America, you need to check that out. And then they hung up the phone. And it's interesting, you'll understand this, Chris, in oncology, we talk a lot about the art of breaking bad news. I don't know if there's a perfect way to do it, but there's certainly an imperfect way of doing it. And learning your cancer diagnosis from a government bureaucrat who then hangs up on you and tells you to go and get healthcare in another country, that basically is about as dispassionate as it gets. So we got to the States. My dad had to have his entire right lung removed. That didn't entirely rid him of his cancer because it was sort of stuck behind his breastbone. So he got radiation to that area, which was at the time pretty crude. This was the late 1980s. And his cancer still spread. So he developed very, very painful bone metastases, and he required chemo near, as it turns out, what was near the end of his life. And so I know this is a really sad way to start our talk, but I'm glad that you brought it up, is to sort of ask the question, why does any oncologist go into the field? And most of us have this sort of personal tug. Now, I have to say, my dad died in 1994. There was a host of sort of technological advances, both in the field and out of it, that he never lived to witness. For instance, he never sent an email. He certainly never did a Zoom call like we're doing now. But in cancer medicine, I have seen so much progress since he passed. I sometimes have this almost thought exercise where I imagine I have a time machine. If I could go back in time, what could I do differently for him now that was not possible then? But two things stand out to me, and I was very young when he passed. I was 14 years old, and he was 49 when he passed away. One is sometimes the right medicine does come along at the right time. So in 1991, he was in the ICU. He had absolutely no white blood cells, zero, after some pretty high dose chemo. And his oncologist came in. I'll never forget this. I was very young at the time. And he had this injection, his needle in his hand. He said, "This is a new medicine that the FDA just approved this week, and I think I can bring your white blood cells back." And that medicine was Neupogen. And it had literally just been approved. And it was like a magic trick to watch this man come in, give this shot to my dad, and then see his white blood cells come back. It was really remarkable. It made such an impact on me. It seemed near miraculous then and now. And the other thing that made such an impact on me was, after my father passed away, his oncologist said, "Well, you seem like you're interested in science," which was a very polite way of saying you seem like a nerd. And so then he had me work in his clinic during the summers of high school and college. And so I worked my way up. I was a medical assistant. I was a radiology tech. But most of what I did was just follow him around. I just shadowed him. And I watched his interactions with patients. And it was such a profoundly humane thing that he did. It wasn't just about the chemo or the doses. It was about these people. And this was the day of paper charts. And so he would literally write information about them in the margins. And it really enriched his view of who they were as people. So there's so much data to process these days. The medical record I have open on my other screen is just absolutely packed with numbers and figures and things I can look at. But there really is no substitute for getting to know someone as a person. And that's a very kind of wishy-washy answer, but it's the truth. And again, part of the reason I want to do these talks is, and I suspect this is a receptive audience, is to kind of personalize cancer care. I think it is very, very easy to lose sight of the people on both sides of the table. Patients understandably often complain that they're reduced to data points. And on the other hand, I want to make sure that patients see us as approachable. And even though some of our treatments have been and remain very toxic, I think most oncologists really do have their head and their heart in the right place.
Wow. We need to bottle that one up. That was, really, you covered so many important topics, but I want to key in on something you said sort of toward the end, which is personalizing cancer care. Because I think a lot of people hear about personalized medicine and they believe that, individual new medicines need to be made for each person or something like that.
Right.
Can you talk a little bit about what goes into personalizing the care of an individual patient, and what are the questions that a patient should make sure they are asked to be able to inform that personalizing of their care?
Yeah, absolutely. So you're right. We're not concocting, de novo medicines per patient. That would be very difficult to do from a quality control standpoint, and even from a scientific perspective. How do you make that reproducible? But to your point, Chris, I would say that there's two things. One phrase I like to use is that we're making every cancer a rare cancer. And that sounds like a very odd phrase on the surface, but the way I look at it is we take very, very common diseases, and colon cancer is a prime example for today's talk. And we ask, okay, is this actually an umbrella that covers a lot of different subsets, and each subset might have its own approach? So that is one avenue to personalization that doesn't rely on the person, but relies on the person and the characteristics of their disease. So that's one thing I would say. And the other thing is, you're right that we're not, again, in the lab making up new potions for every patient, but we are learning to repurpose drugs. And one of the things I find really interesting in oncology is how one part of the field will benefit another, sometimes in very unexpected ways. So there are now medicines I use as a gastrointestinal oncologist that are quite honestly stolen or borrowed from, say, my breast cancer colleagues. Or there may be a drug that works in melanoma that also works in a subset of colon cancer. So it's a really exciting time for cross-fertilization. But back to your original question, I think it's really important for patients to understand as much as they want about their care, and also realize that just saying I have colon cancer, that's really an insufficient description, at least to an oncologist, of someone's disease state. We would want to know so much more about that. We'd want to know stage. We'd want to know what side of the colon it came from. And then we'd want to know these sort of molecular characteristics, almost like the fingerprint of that cancer. And then my final thing I'll say, because I know I'm long-winded, is that can actually change over time. It's very common even for oncologists to sort of anchor on all these details at the time of diagnosis. But if you're fortunate enough to get to follow someone over the course of years, not only is that a very enriching longitudinal relationship, but the cancer can and often does evolve. So not only is it a thing you need to understand at the beginning, you basically need to reevaluate that understanding every time you're at a fork in the road and you're trying to decide what to do with treatment. So that's my kind of, again, long answer about how we personalize care. It's not about making every single patient an N of one when it comes to their treatment, but it is about trying to make sure that you are distinguishing them and the specific characteristics of their disease as much as possible, so that the treatment can be as targeted as possible and thus less indiscriminate in its side effects and hopefully more beneficial too.
Yeah, it's so great. I mean, I think from the customizing the treatment, I think that is something that, most patients are probably going to have to rely on their physician. And one of the things we talk a lot about in this series is that that most physicians who are really carefully thinking about how to manage your care are not going to have a huge problem if you go get another opinion, because sometimes another set of eyes is just a fresh way of looking at things. And it might be the opportunity to say, hey, you haven't done this test that came out 6 months ago and actually influences treatment decisions. And it could be just because your physician is so used to seeing you and managing what's in front of them that they've just kind of forgotten to go back and start from scratch again on your case. So yes. I think that's a really important example. The other one we've talked a lot about is not really just on like, what is the next treatment you're going to get, but what are you trying to accomplish? Yes. What is your goal?
Yes.
And how would you like to get there, or what would you be willing to give up for one goal versus another? Maybe that's something you could touch on, because you've probably made some of those decisions for yourself and helped patients, made plenty of them.
Right. And that can change over time too, right, Chris? So again, I do see sometimes this pattern of these really important questions only being asked once at intake. Mm-hmm. So for instance, we are supposed to document at the very first visit, what is the intent of treatment? And very broadly, are we trying to cure your disease, or are we trying to control it? And as you know, that's sometimes called palliative intent. And there's some, wordsmithing to do there so people don't confuse that with hospice, but regardless. So that's supposed to be documented at the beginning. But what I don't find necessarily is revisitation of that goal, especially if treatment does not go as planned. So sometimes, with the best of intentions and all the scientific rationale in the world, a given treatment might not work for a given patient. And even there, work sometimes requires definition. Some of my patients, our definition together, what works is just controlling disease, preventing growth, preventing organ dysfunction. That, for some patients, is a reasonable endpoint and one that they accept. For other people, that's not good enough. And they want, understandably, to be rid of their disease. They want a durable remission. And we're sometimes very cagey about using the word cure. In my mind, what cure means, so that we're not, over-promising to patients, is a remission that lasts for 5 years. That's the traditional definition. But again, you're right that we need to keep coming back to this again and again. You mentioned myself as a patient and how that colors my view of this. So as far as I can tell, I'm never going to be cured. So my genetic condition affects every cell in my body and makes certain organs in particular prone to developing cancer. So I had a pancreatic cancer operation now 5.5 years ago. And you mentioned Twitter. Wisely or unwisely, I used it to live tweet that procedure. And I say of course, I was under anesthesia. My employer did it for me. But it was really a remarkable experience to come out and have all this support from the online community. But really the reason I did it was, A, I wanted to demystify that particular procedure because it's kind of a scary operation. And B, like you're saying, I wanted to lay bare, why do we do these things? Why does anybody choose to do something as radical as either a pancreatic surgery or chemo? Because I say all the time, nobody wants chemo. Nobody wants chemo. But some people need chemo. And our job is to reasonably convince someone that chemo is more likely to help them than harm them. That's what it comes down to. When I first started in my fellowship, and Sarah very kindly read my CV, it struck me as a near impossible sort of task as a salesman to tell somebody, hey, here's these noxious chemicals and I'm going to put them in your body and you're going to accept them. So to do that voluntarily, I realized that you have to exchange information. You have to show them, okay, this is what could happen on the sort of adverse effect side, but this is what we hope will happen on the benefit side. And again, by using myself as an example, I knew this pancreatic surgery wasn't going to cure me, but I also knew or hoped that it would prevent metastasis to my liver. And so far it's done that. So by living that out and doing it partly online, it's actually been really rewarding because some patients who are searching online will find me and they'll think, well, this guy hasn't had chemo, but he does understand decision-making from a patient perspective. And maybe that will inform the conversations we have in clinic. And that's been a very rewarding feedback loop because, as I'll tell Shauna, I mean, I learn from my patients all the time. I sometimes feel usually feel unbelievably privileged that I get to learn from them about how they handle their disease. And that honestly, that helps me as a patient. So it's a beautiful sort of two-way street.
It seems like a perfect transition to introduce Shauna and maybe talk through the details of her case a little bit. Can I just turn that over to you to start that conversation?
Of course. Well, Shauna, it's nice to see you in this venue. I know you're used to seeing me in clinic. And first of all, you and I are normally masked. To see your smiling face is a real treat for me.
Thank you.
So one of the reasons I'm so thrilled to talk to you, and this is not just me paying you lip service in this forum, is you are far and away one of my most informed and self-advocating patients. And I think this is a force in healthcare for the good. Rather than sort of rob you of the microphone, I might just allow you to tell the audience, to the extent that you're comfortable, a little bit about your history and how you've gone about learning as much as you have about your cancer. Because again, I'm not just, buttering you up here. You really understand it at a remarkably high level.
I was diagnosed in the ER, had belly pain that had been going on for about a month off and on, and it was getting more and frequent and intense. So I went to the ER. And they did a CT. I self-diagnosed that I had diverticulitis, but obviously that wasn't the case. But I had to have a CT in order to, figure out what the diagnosis was. And it showed a transverse apple core tumor in my colon. And also it showed a couple spots in my liver at that time. So I was automatically stage 4 right from diagnosis. And this diagnosis actually happened to take place on March 14th of 2020, which was just a mere week or a few days before the whole world shut down for COVID. So it just really coincided with the whole world was in chaos, and my life especially, because I was having to go through all this right in the middle of all the COVID stuff that was going on. And they just assigned me to an oncologist, not you, but a different oncologist. And I was with her for about a year and a half. Mm-hmm. And then I just felt like I needed another opinion and maybe somebody who specialized in GI cancers. And I asked around on several forums and also to Dr. Zendejas, my liver surgeon, and the consensus was you. So I came to see you for a second opinion and was very pleased with your take on my care. And I switched over to you at that time. So it was about a year and a half ago also.
Yeah.
And since my diagnosis, I've had 2 bowel surgeries, 3 open liver resections. I had to have a major hernia repair, which honestly was my hardest surgery to recover from, as well as some heart stuff that has come up. I've had 3 heart surgeries, not open heart, but through my wrist. They accessed my heart through my wrist. Got a pacemaker put in. Anyway, I've just been through a lot. But at this point in time, I'm in remission. No evidence of disease, and I'm so excited about that. I guess technically it's been since August when I had my last liver resection. So going on about 6 months now, and very, very pleased about that. And one of the reasons that I switched to you, Dr. Lewis, was because you were a big believer in liquid biopsy testing, which my previous oncologist was not. and I learned through several online or Facebook groups that I'm a part of how important that was, especially since CEA is not a good diagnostic tool for me. And I wanted something to be able to tell if the cancer was present, microscopically in my body. And I felt like liquid biopsy was the best route. And so when I found out that you were a believer in that new technology, I knew that you were my new doctor.
Well, and it's been absolutely wonderful to have you in my practice, and your own good health is just such a rich reward, Shauna. So thank you for all of that. You said a couple of things in there that I think sort of, again, give jumping off points from what Chris and I were talking about earlier, one of which is this notion of a second opinion. I personally think, and I know a lot of brilliant doctors, I don't know a single oncologist that knows everything. It just doesn't exist. And we have this beautiful problem, which I view as breadth versus depth. And you actually already kind of hinted at this in your answer. So I'm very lucky in that right now, and for the last 6 years, all I have done is GI oncology. And believe me, under the GI umbrella, there's plenty to do. There's lots of stuff going on with the colon and the pancreas and the esophagus and everything else. But most oncologists don't have that privilege. Most oncologists are generalists. And I've done that before too. And just to step back, this is not like a pity the physician, appeal. But if you think about the amount of information that we are trying to keep up with, sort of this task of lifelong learning, it's actually really hard, like I say, for a oncologist, specifically in community practice, to keep up with everything. So because there's a lag sometimes between sort of the newest technology and then the dissemination of awareness of that tech, you do sometimes see this lag. And that can lead, very forward-thinking patients like yourself to say, well, if I ask my doctor to order a test for me and they express reservations or they even say no, how am I going to get the test? And then people start kind of looking around. What I want to validate in this forum is you can absolutely ask for a second opinion. Your doctor, in my opinion, should almost unreservedly grant it because that's your right. But that doesn't necessarily mean that has to disrupt your therapeutic relationship. And what I've found more and more, so I live in Salt Lake City, near Shauna, but I serve an 8-state area with my healthcare network. Most of the time what I'm doing is offering recommendations to other doctors that they then enact with their patients. I'm not trying to sever an existing alliance. And I guess what I'm getting at is you can get a second opinion. You can still go back to the first oncologist. And I actually see this happen quite a lot, especially around clinical trials. So we haven't gotten to that part yet. But part of what I love about patients who are as self-advocating as you, Shauna, is you help me stay current. So particularly when it comes to research, that is such a dynamic landscape that sometimes, and I'll readily admit this, sometimes trials will come to a patient's awareness or a support group's awareness before it comes to mine. And I love it when patients like you come in and they're like, hey, Dr. Lewis, what do you think about this trial? And I look it up. We make sure it matches you or doesn't based on the inclusion or exclusion criteria, respectively. And we talk about, okay, should we enroll you in this? Should we wait? Should we borrow some principles that they're using here? So I personally find that dialogue very enriching. I will confess there's a power dynamic here that I think we need to acknowledge. So there's still the sort of, mismatch between, I've got the, prescribing ability and the patient doesn't. But I really think we're getting away from the era of paternalism, like where I would walk in a white coat and I would dictate what's going to happen. That was never ethical. And I think it's becoming increasingly passé. And what I like, this model we talk about of shared decision-making really respects both sides. It respects the experience of the physician, but just as importantly, it respects the self-awareness and goals of the patient. So, Chris, as we try to kind of stitch this all together, I think that what we're seeing is that second opinions are completely appropriate to ask for, especially if they, are addressing a novel tech or maybe a trial opportunity. But I still think that you can have a great relationship with your oncologist in a general sense while seeking subspecialty expertise. But maybe that's just my take.
No, I think these are great points. I mean, look, in 2001, I probably would have said, I'm not totally sure that people are going to be texting each other with phones, right? Like that doesn't make any sense.
Yes.
And then, somebody tries it and they go, this is pretty convenient. And then before you know it, like you're walking around with a computer, like a supercomputer in your pocket, and you're change your entire perspective. And I think it's similar with a technology like circulating free DNA or whatever it might be, that if somebody has never used it, there is such a big difference from what would I ever do to understand this to like, oh, I used it and it really helped me make an important decision. That initiation energy can be so big,
yes,
that it just prevents people from trying new things. And sometimes, to your point, seeing that done with your patient by another doctor, or having it recommended to you by another doctor, and even some guidelines about how would you interpret this when it comes back, is just a really helpful tool. Similar to how, I'm sure many of us have this experience of like having to help somebody find their password for their iTunes account so they can, like get back on track. Sometimes you just need somebody else to sit there with you while it's so painful that you figure something like that out. And I think the case that you're giving, right, of somebody being resistant to using a new technology is something we see in medicine, throughout all medicine, not just cancer. Although I think it's more common in cancer just because of the rate at which cancer therapy and decision-making is changing. It's changing so quickly that, it's almost irrecognizable from even before I started fellowship, right?
I was just saying the same thing.
That long ago.
Right.
Yeah.
So Chris, when Sarah was reading my resume, I was reflecting briefly on like my fellowship, my training, and I loved it. And my faculty were awesome, but almost nothing that they taught me in terms of the actual treatment is still relevant today. Like, and I've been out of fellowship now for 11 years. So, what it teaches you to do is it teaches you how to give things like chemo safely. It hopefully teaches you like the framework of how to have sometimes very difficult conversations with patients and be authentically there for them. But the science is changing all the time. And so I saw Carly put in the chat, when asking for a second opinion, how does a patient make sure they're getting a second opinion that's not just going to back up the primary doctor? So Carly, I have no problem sort of pulling back the curtain here. What I would say here is that usually the person from whom a patient would seek a second opinion has some sort of, how should I put this, some sort of bona fide credentials to be offering that. So for instance, like I said earlier, I'm lucky in that I'm a subspecialist. I'm not a generalist, so I just do GI. But that's not the case of like 85% of the oncologists in this country. And if you think about it just from a practicality perspective, it actually makes sense that most of our cancer doctors are going to see most tumor types. That's the best way to sort of distribute that expertise and that workforce. So I don't know about you, Chris, I almost never see, just out of pure deference, reinforcement of the first doctor's sort of judgment. In fact, it's usually, to me, the other way around, where the person offering the second opinion, like you said, is viewed as helpful because they have, again, the time and probably the experience with either a new tech or a new treatment. And then they can reassure the first physician that this is a prudent course of action. It does take a little bit of delicacy and diplomacy to do this and not step on toes. So I'm not saying this always happens in perfect harmony. But the last thing I would say is, the patient, and I realize it doesn't always feel like this, but the patient really has the power. Like, so Shauna, for instance, had the opportunity when she first met me, in my opinion, and Shauna, you may have felt otherwise, to sort of take what I had to say and take it back to her first doctor, but ultimately she chose to stay with me. I know that's not always possible. I know second opinions can seem like a luxury, especially geographically. But the last thing I'll say on this point is the exact forum that we are using right now, to me, has made second opinions much easier to attain. So this whole notion of virtual visits, because let me be honest, the physical exam is important, but I can usually tell about 90% of what I need to know about a patient from these kind of interactions, like reading their chart, talking to them in this manner. And so what I'm getting at is second opinions in my mind are likely to become more frequent and easier to get rather than less so. And then I see here in the chat, Shauna, is an educated patient. How do you treat a patient who knows nothing when they come to you? Okay, I'll jump off on that. And then Chris, I'll make sure you're allowed to continue hosting. Shauna is the exception to the rule. You go in not expecting ignorance, but you do have to assess at the very beginning, hey, listen, what do you understand about your disease? And I think also crucially, what do you want to know? Some patients, I'll be very honest, are actually very comfortable with the paternalist model. I would say, as a general rule, this tends to be some of my older patients, and they were used to an era, like my grandmother said, where you don't question the doctor. I'm not sure that era was ever quite appropriate, but regardless, there are some people who say, listen, Dr. Lewis, you went to school for this, you're in the driver's seat, and just tell me what to do. But that is a tiny minority now of my practice. And frankly, I'm more comfortable if someone comes in and they want to know something about their disease and they want to have some say in the treatment decisions. So there's a baseline assessment we do of what people know. The easiest way actually to figure that out is when they arrive in your office, ask them, why are you here? And I know it seems almost judgmental, but just the way someone relays to you their medical history tells you a lot about their level of understanding, their level of savvy. Someone like Shauna is going to come in and they'll know about the molecular features of their disease. Other people are not going to come in and say, hey, I've got a BRAF mutant colon cancer and I've been through XYZ treatments. Sometimes they come in and they just say, I have cancer. I'm here because my primary care doctor sent me here. And then you're like, okay, we're going to start at the very, very bottom and build up. The last thing I want to say here is I don't do this alone. I work very closely with nurses and nurse navigators who actually do an intake assessment, usually before I've ever met the patient, and they give me a sense of where that person is at educationally speaking in regard to their disease. And I think that informed consent ethically is predicated on the patient having at least some understanding of what's going on with them and what they're signing up for when they agree to treatment.
I'll give a couple of additional thoughts based on the comments that are in the chat that everyone can't see. So a lot of this is revolving around how do you know, how do you find the right person? How do you seek out? And the truth is there isn't like some, playbook for that, right? It's, you got to join, up with an advocacy group and ask their opinion. You might go to your local cancer support group and say, hey, I have this. Does anybody else have this? Who did you see? But I do think there are a few principles that you really do want to stick with. One, if you have a new diagnosis and it's not super, super straightforward, which most cancer today isn't, let's be honest, you want to find somebody who is an expert in that thing, whatever it is. So, if you have colon cancer, you might say, I want to find a colon cancer expert. But even within colon cancer, there might be sub-experts within that. And I can't stress enough that is something that you can find on the internet by just doing some Googling. It's really, I know it sounds like I'm making it sound easy, but if you type in like just a few keywords about yourself and your location, you're probably going to find somebody at the closest major academic center who works only on that particular question, because that's how many problems there are in cancer that all of us are thinking about. And so somebody is going to be really focused on that particular thing, usually, not always, but usually. And if you don't find somebody local to you and you do find somebody who's, 2,000 miles away, email that person and say, who do you recommend close to me that it might be not as well known as you, but is really, really good, right? The other thing is, and this is a hard one, but if you ask your doctor, who is the best in this area at this thing, and they don't know, you might want to think about whether you need a different doctor anyway, right? And number two is, if they don't encourage you to go see that person, you really need to think about whether you should be in their hands for the rest of your life, right? I know this sounds like I'm attacking, I'm not. When I would see somebody for a newly to me, because I only saw people sort of with end or later stage disease, the first thing I would tell them is, I'm going to tell you a bunch of stuff, and I want you to go ask at least one of these other 3 doctors I recommend in this area to see if they have a different opinion than I do. And I'm not going to email them what I'm saying. I just want you to go see them. And the reason is, I want to know if they disagree with me. I don't want to do the wrong thing for the patient or for anybody. So every doctor needs to have a level of humility coming into these conversations, and that is not normal always. So, feel free to probe on that, and you absolutely should. And patients should feel entitled to do that, because you are fully entitled to get the best care.
It's your life, right? I mean, patients are the ultimate stakeholders, Chris. I totally agree with everything you said. And I know it's uncomfortable. It feels like we're authority figures, and I know we hold the prescribing pen and all of that. But this is your well-being, and it's important that you feel comfortable in the relationship that you have with your oncologist. One tiny added tip I have on top of your Google suggestion is using clinicaltrials.gov to your advantage. So it's far from a perfect database, but I think it's gotten a lot friendlier in the last couple of years, especially in terms of being patient-facing. So if you go to clinicaltrials.gov, which is, again, the repository of all the studies that are happening, you can put in a term like colon cancer, and then you can put in where you live and how far you're willing to travel. And my point is not necessarily that you want to see all the studies that pop up, but the names associated with those studies can be very helpful. So, for instance, Shauna is an expert in her type of cancer, and she knows all the relevant researchers who are really doing the cutting edge trials. In fact, she got to meet some of them recently at a conference. It was really awesome to see those pictures. It was like interacting with, GI oncology rock stars, right? So that's another way of doing it, is that the government makes this search engine readily available to all of us, and it is actually a very useful tool. It's actually what I use. Like if a patient like Shauna comes to me and says, "Hey, Dr. Lewis, what are my trial options?" The first place I always go is that database, and it has to have, associated with trials, the contact information of the physicians who are running them. So that's another way, Chris, I think that you can get the names. And the final way, as Shauna and Erica are exemplifying, is the crowdsourcing of other patients. Now, my one caveat here is I do sometimes see the I don't know if mistake is quite the right word, but I see this practice of extrapolating my experience as a patient to your experience as a patient. And that's hard to do. No two people are exactly alike. On the other hand, if you've had a good experience with a doctor in a specific disease type, and you want to share that feedback with another patient, I think that's entirely appropriate. And that's really, I think, one of the most organic ways that referrals happen, is that patients who are alike will flock together on venues like this one, or online support groups, what have you. And then they tend to exchange information back and forth. And again, what's most helpful, I think, is not the, "Oh, my CA is this and your CA is that." It's, "This was my experience in this practice, and this is the technology that helped me." I did see in the chat this notion about, well, what do you do if a doctor won't order a test that you want? That I admit is a very, very difficult situation to be in, because you can't order that test on yourself. I think probably the best way of going about it is to present it non-judgmentally as you're building a case with evidence. So personally, I find it quite refreshing if a patient brings me a paper. Sometimes the paper has no merit. Sometimes it has robust proof behind it. So I know it's a really tricky balance. That may be another case of seeking a second opinion just to get the diagnostic test that you're looking for. And I know Shauna, actually, from her testimony, that's maybe one of the reasons why she came to my practice, is she was interested in circulating tumor DNA. And I was a little bit farther along in my use of that than one of my local colleagues. So Shauna, I don't know if you have any advice for Danielle there, but it sounds like these new technologies they're not uniform in their rollout.
That is absolutely for sure. And I'm just so grateful that I found you, who was up on the latest and greatest technology with circulating tumor DNA, and I found it to be an extremely useful test for my benefit, and I think for your benefit.
Yes,
as you've treated me, and I'm grateful somebody designed this test and made it available to us.
So we've actually covered the topic of circulating tumor DNA previously with Chris Liu, who I think you know well,
yes,
Mark. But and I know you have a significant overlap in your area of interest in research too. And I do think, since we can't assume that everyone has viewed every one of these videos. In fact, we know not many people have viewed most of these videos. So we do encourage you to go back and look at the ones that that might help fill in the gaps. But would you mind giving us maybe the 2-minute primer on why circulating tumor DNA is helpful, how it might be helpful in an individual case like Shauna's, and when it might not be also, right? And like why a doctor might say, I'm not really sure what I would do with that.
Yeah, I'll actually probably answer that in reverse, Chris. So, we are human beings. So newsflash, oncologists are people too. And the reason I say that is we have cognitive biases. And one of the things that we do is we anchor Okay. So I mentioned earlier about my training. Don't get me wrong, I was at the Mayo Clinic. My faculty were amazing. I loved it. But very, very few of the things that they taught me there are still relevant years later. It is hard, though, and this is what Chris was saying with the activation energy. It's hard to break habits. I don't know about you guys. We're about 2 months in the new year. I've not kept all of my resolutions. So it is very difficult to change someone's behavior when it's been ingrained in them or when it's been taught to them. So again, oncologists are having to come around to this notion that what we learned is not nearly good enough. And it's hard. Again, I'm not saying you have to pity us. We were very lucky to do what we do. But imagine that you trained for years to do one thing, and now your field is moving so fast that you basically are constantly having to change what you do. And that adaptation is I think one of the responsibilities of the field, but also one of the hardest parts. So that's the first thing I would say. The second thing I would say in terms of anchoring is people go, and I'm peeking behind the curtain here, oncologists go to either their peers or peer-shared resources when they need to make decisions. So again, Chris, I apologize if you covered this in other videos. There is this national group called NCCN, the National Comprehensive Cancer Network. It is a group of largely academic institutions and experts at those institutions who put together guidelines. So for instance, it gets very, very specific. There is a different guideline for rectal cancer than there is from colon cancer, than there is from small intestinal cancer. So we're at that level of granularity. And so most doctors will go there to sort of cross-check their decisions and see if they line up with, a standard of care that experts have stood behind. So here's my point. Sometimes tests are so new that they have not yet made it into those guidelines. And so say a doctor is not familiar with the technology, in this case, circulating tumor DNA in colon cancer. They might go to the NCCN guidelines and ask reasonably, hey, is this something everyone's doing? Is this common practice, or is this some sort of novel technology I need to learn about? So the last thing I would say to you, Chris, is I think about cancer, and maybe you do too, as an adversary on a cellular level. And I say that because for years, and Shauna is a perfect example actually of going as far down as we can in terms of resolution to assure her that she's in remission, that she doesn't have any detectable cancer. But for years, it was as kind of rudimentary as, can we see something on a scan or not? And I love it. Don't get me wrong. I love it when patients have reassuring scans, but we also have to be honest as your physicians. What is the level to which those scans can reasonably detect cancer? And the scary answer is, let's say you're talking about a CT scan. CTs are just X-rays that are put together, slices of X-rays. And so in the width between those slices, you can miss cancer cells. And so where circulating tumor DNA is useful is, as Shauna already mentioned, there are certain cancers that will shed their very distinctive DNA into a patient's bloodstream. And then you can find it there if you look for it. And that to me is a much more sort of personalized, use that word again, approach than using conventional tumor markers. So Shauna already mentioned that CEA, or carcinoembryonic antigen, doesn't work for every colorectal cancer patient, just like another tumor marker called CA19-9, cancer antigen 19-9, doesn't work in every pancreatic patient I take care of. So it's one step closer to individualizing care and really trying to be as sensitive as possible in every sense of that word to the detection of minimal residual disease. So I know there's a whole other primer on circulating tumor DNA in another video you've made. That's the way I look at it, is it's basically a rapidly evolving new technology that allows me at least to go below what I think is the threshold of detection on, say, a scan.
Yeah, and I want to point out that and tell me, because obviously I don't know Shauna's case nearly as well as you or Shauna does. But in Shauna's particular case, there are a couple things that are really important to highlight. One is, if you don't get a sample at the beginning, it's actually really hard to know how to interpret the results later. You need to have a good sample to do this well. And the other part is that when any theoretical possible of cure is out there, you don't know when you're going to get there or not. So you can't say, oh, I'll just do this later when things are heading the right direction, because you might have missed your window to capture the right sample. And I think this is just one example of how, there's a great example of how quickly things evolve. If you had asked somebody 20 years ago, does Shauna have any chance of cure when she came to you? You'd have said, no,
right,
probably not.
Right.
But since then, we know that patients who have great responses and a resectable liver metastases have some very real chance of being cured or, having very, very long-term remission or no evidence of disease. And those things evolve so quickly that if you'd asked somebody 15 years ago in the community, should we treat this patient with the possibility of cure, they still probably would have said no.
Yes.
And it's just wild, right? Like how quickly those things happen. So I think this Shauna's case actually highlights a few points for us. It highlights that the decision tree around potential curative therapy is different from one year to the next in a lot of cancers. And then the tools that you use to detect that can be different from one year to the next. And when those two things converge, you can get a lot of misinformation or a lack of information from any given person. And that's why these second opinions are really helpful.
Can I say two things there, Chris? I'm sorry to interrupt you. Well, one of which is, like you said, is actually, I think, very appropriate to talk about Shauna's case in regards to the liver disease. So she mentioned this in passing, but, a key part of her team is her liver surgeon. And, as a GI oncologist, almost all blood flow from the gut goes to the liver. And so the organ I actually worry about the most in my patients is not their colon, it's their liver. So I have seen in my career the remarkable evolution of what a liver surgeon will consider, to your point, curable. For a while there, it was, if there's a single spot on one side of the liver, we might be able to handle that. And now, again, as Shauna can tell you, it's a lot broader. It doesn't mean everybody is a candidate, unfortunately, but these things absolutely have to be discussed with the specific expert for that indication. So real quick, just to reassure everybody on this call, almost every oncologist in the country at least has access to or regularly attends a tumor board. So the way tumor boards work is it's kind of like on Who Wants to Be a Millionaire when you phone a friend. It's you bring a case, you usually have a particular question or questions in mind, and you present it. And, like if I was going to do Shauna's case, I could probably summarize the really salient details of her cancer in a sentence or two for my colleagues. And then we would all look together on a big screen at scans, and sometimes we look at pathology. My point is, increasingly, this whole notion of oncology as a team sport is really acknowledging the multidisciplinary nature of what we do. I'm not a liver surgeon. I'm not a radiation doctor. I am a medical oncologist, and I need help from my colleagues to do this. So that's the other part, is whether you know it or not, tumor boards exist. I actually try to make a point of telling my patients when I'm presenting that tumor board, because it feels to me like a built-in and free second opinion. Because you've discussed that person's case with other physicians, and thus you're not just making a choice for them in a vacuum.
I feel like we should repeat that every one of these episodes. It's so important. If your doctor isn't discussing your case in a tumor board, you should ask why. I mean, it's really an important part, because none of us can really do our jobs without the other physicians who have different subspecialty care or capabilities to, you need a surgeon, you might need a radiation oncologist, you might, there's all sorts of support that you're going to need to take care of patients well. So it's a really good point. I did want to point out, though, the thought I was trying to finish in a much too long-winded fashion was that there are cases where using circulating tumor DNA can not really change the decision path.
Yep.
And I don't want to have everyone leave this conversation like, oh, I should always get circulating tumor DNA.
Yeah.
Because if you have advanced like metastatic disease and you're trying to make decisions about what therapy to use next, the circulating tumor DNA may not be that helpful. In fact, it may confound the picture for you a bit.
True.
And so, again, I think for individual patients, it's really helpful to talk to someone who knows the technology well and say, what have we learned so far from clinical trials and from individual patients that you can apply to me, and not assume that everybody everywhere needs circulating tumor DNA to be performed at every visit. So I don't want that to be the takeaway. And Mark, it seems like you agree, but
so well said. And again, I know we're not like invoking specific brands here or specific products. You're right that they're all different. Just like every other test, they have their specific, what we call performance characteristics. And so, the words or principles that matter to us are sensitivity and specificity. Sensitivity is if someone truly has the condition, how likely are they to have a positive test? And specificity is, if someone doesn't have the condition, how likely are they to test negative, generally speaking? And so how those two characteristics balance, it really matters when you're considering the usefulness of any given test. I do want to address very briefly in the chat, there really is currently no standard time to do circulating tumor DNA. And as Chris said, it can vary by patient. I will say though, Stephen, I think one of the most interesting uses is in, say, stage 3 colon cancer. So again, without getting too specific here, one of the weirdest things I do as an oncologist is give chemo to patients with no detectable cancer. So adjuvant chemo. So a surgeon has cut out the cancer, and they'll sometimes use that fateful phrase, "We got it all," which surgeons love to do. But in truth, as good as they are, and as skilled as they might be in the operating room, no surgeon has the vision to see on a cellular level. So often the medical oncologist comes along, looks at the pathology, and assesses the likelihood of there being cells left behind or not. And to date, really until these circulating tumor DNA assays came along, we were basically going off statistics and studies and not necessarily personalizing that decision. And again, if I go back to when I was a trainee, I remember the first time I sat down with a stage 3 colon cancer patient, and I told them, on the one hand, I can't see any cancer. Congratulations. On the other hand, I think you should do 6 months of chemo. And to make those statements so that they weren't contradictory, I had to prove to them beyond a reasonable doubt the likelihood of there being cells left behind. So where I think ctDNA is actually the most interesting and is likely to help the most patients, and we have studies that are ongoing for this, is to use it as a tool to decide who gets that mop-up chemo and who doesn't. And already in colon cancer, we got some very exciting data, especially from our Japanese colleagues, that we're going to try to duplicate here in the US. So watch this space, but like Chris is saying, I don't want anyone leaving with the impression that A, this technology is for everybody, or B, it needs to be used at every decision point, or to your point, Chris, supplant some of the more traditional markers of response or progression.
Yeah, I also just want to tack on one more time for everybody what you just said about sensitivity and specificity. Those are statistical terms, and we assume that an excellent test will be about 95% each, right? Yep. Which means that it is wrong about 5% of the time, even when it's amazing.
Yep.
Most tests are not that good. And so when we, as oncologists, talk about likelihood and probability, we're talking on population level. So based on patterns that have been observed in clinical trials and across thousands of patients. But the reality is that for any one patient, probability only can be weighed by like what happens to me over time.
Yep.
So it's a lot of times maybe it's only a 5% chance of a bad outcome, but it's binary for you.
Yes.
So it's like, well, if it's only a 5% chance, but I can reduce that risk by doing this, is that worth it to me or is it not? And ultimately, that is a decision that patients have to make. It's such a hard, because most human beings are not trained to think about probability in their day-to-day life. Mark, it seems like you want to comment on that.
Oh, yeah, no, I was just going to say, again, I started my fellowship in Mayo. I was in the middle of the Minnesota tundra, and it was a fascinating place to practice because about half my patients were what we call medical tourists, not as an insult, but people that came there for treatment. And the other half lived locally. And it was fascinating to me, Chris, I'm going to sound like I'm stereotyping here, but just how differently people interpreted statistics. So for instance, someone that came to Mayo seeking treatment was often willing to incur all kinds of toxicity for even a 1% chance of greater survival. Then on the other hand, I would be taking care of some of my local residents. And I'll never forget this. I was taking care of this farmer, and I don't mean to make him sound, stereotypically anything other than a very, very smart man. But I was giving statistics to him just like I was to my other patients. And he said, "Dr. Lewis, let me stop you right there." He's like, "I don't care what numbers you give me." And this is to illustrate your point. He said, "For me, it's either a 0% chance or it's a 100% chance. So just exercise your judgment. I'm going to do what you say." And that struck me because you're right. It's ultimately binary. For that 5% who might be missed by a very sensitive test, that really matters for them. It's great for the 95% who it was a useful test, but it's hard for the 5% who quote unquote miss out. And I see Stephen commenting about the the ctDNA. It can actually be binary there, Stephen. I agree with you in terms of, is there minimal residual disease or is there not? Again, within a reasonable doubt. But yeah, watch that space. I think it's going to inform almost everything that we do in oncology, especially with adjuvant.
I think you're right. I think one of the other things that will be really compelling about circulating tumor DNA is when we get to a point where there are known predictive risks of the likelihood of ctDNA saying, yes, I can trust this 100% of the time,
Yes.
or no.
Yes.
And we're not, I would say we're not quite there yet from any data set I have seen, but truthfully, there are very few tests that are that good at all in any part of medicine. So even like Dr. Lewis just told us, even a CT scan, it misses, you can miss stuff. And that's about as good as you can hope for in terms of imaging. So I wanted to just comment one thing, though, that you just brought us full circle. So we started talking about personalizing care, and we're talking now specifically about how you might make this decision about adjuvant or no adjuvant therapy. But even in that conversation, right, even acknowledging that a totally negative circulating tumor DNA post-op might lead you down the path of let's not do the adjuvant chemotherapy, there might also be a patient who says, I don't care what that number says. Give me my FOLFOX, right? And I think this is just coming back to that first part of the conversation. That is when you as the patient need to decide who you are and what you're willing to risk or not, right? Just as an example, I have a family member who is a trained medical professional who is taking care of a certain type of cancer her entire professional career, was diagnosed with that, and knew everything you could need to know, and then made a decision I never would have made in her position. And we had this conversation. We're very, close, but she said, I'm going to get everything, right? Like, I'm going to get every therapy possible in the adjuvant setting. And I was like, these things don't come with no risks, right? They're real. And that's just the kind of decision that two very well-informed people can make very different decisions about these things. And one is not right and one is not wrong. That is what you as a patient need to sort of think through and ask the right questions to get to the bottom of.
So Chris, I know we need to wrap up. I'm going to say something really quickly on that. When I was first diagnosed, when I first found tumors in my pancreas, I was given three options. One is watch. One is take out half your pancreas, which is what I ultimately did. The other was remove your entire pancreas, just eliminate the problem. And so I think what you're getting at is in that case, it's not binary, it's three choices. But any given patient might choose one of those three things based on their own preferences. There's no necessary concrete, this is the right thing to do. And I got those three opinions from three different, very respected surgeons. And so I know we're kind of ending on maybe a murky note, but I think you're right. This is not to disenfranchise patients. Ultimately, it's to empower them to make the choices that are the best from them.
Yeah, part of what we try to do here is give people the reality, right? The reality is this is hard, right? Nothing is going to be easy when you're diagnosed with something that you hoped to avoid your whole life, right? That's hard. And for most people, they're really trying to learn a lot of information very, very quickly.
Yeah.
And so I would just encourage everyone, you can go back through this video series. You can reach out to the whatever the advocacy foundation is for the type of cancer you're diagnosed. That is, I couldn't encourage that more. I think that is one of the best ways to get connected to a good community and figure out what questions you even want to ask, let alone what the answers to those questions are. We'll end on this note because it's probably where people will find the most enjoyment over time. How do people find you on Twitter? There it is. It's at Mark, no space, Lewis, no space, MD.
That's right.
At Mark Lewis, MD. And trust me when I tell you, you will not find a more sort of uplifting, educational, patient-focused Twitter account than Dr. Lewis's. It's really one of people I know in medical oncology around the world, one of the favorite follows for everybody I know. So
thank you so much, Chris.
All right. Well, I think we are going to wrap up on that note of really diving in deep on this individualized patient decision-making and using the tools that we have. I want to thank Dr. Lewis again, not just for this conversation, but for everything you do for the medical oncology community. It's really nice watching from afar and knowing there's like a really good person out there doing great work. So I think I speak for a lot of people when I say that. So thanks again for being here.
Thank you. And honestly, this has been a wonderful chance to chat. Shauna, it's been a delight to see you. Like I said earlier, I never get to see your face. It's usually masked. So this has been very pleasant. And I've really, really enjoyed it. This group does amazing work. And thank you to everybody that promotes patients as their own best advocates.
Thank you. So I would like to thank you all, to our viewers who joined us today, and a special thanks to our experts, Dr. Chris Heery and Dr. Mark Lewis. And once again, I'd like to thank our founding partner, Seagen, and our supporting partners, Colorectal Cancer Alliance, Natera, Colon Cancer Coalition, and Mirati Therapeutics. And we look forward to seeing everyone next time on Live at One Cancer Place.